Hello, and welcome to this medthority.com VTE Learning Zone podcast on cancer-associated venous thromboembolism. My name is Jeff Barnes. I'm a cardiologist and vascular medicine specialist at the University of Michigan. And it's my absolute pleasure to be joined today by Dr. Anita Rajasekhar, a hematologist-oncologist from the University of Florida. And we're going to be talking about care of patients who have cancer-associated VTE. Anita, thanks for being with us.
Thanks for having me, Jeff.
You know, I want to start out with sort of this, maybe the most common question I get whenever I'm helping to care for a patient who has a cancer-associated venous thromboembolic event, which is, which anticoagulant am I supposed to give them? And how do you think through this? And in particular, this sort of low molecular weight heparin versus direct oral anticoagulant decision. How do you look at the data that's been published and apply that to selection for your patients who have a cancer-associated VTE?
Yeah, so in my head, the way I think about it is, first of all, what does the evidence show? And then we can kind of get into, what are patient preferences along with that. So, for at least a decade or so now, low molecular weight heparin has been considered to be the standard of care since about the early 2000s, when there were a few randomized trials that looked at low molecular weight heparin compared to warfarin in cancer-associated thrombosis. And low molecular weight heparin was the winner in terms of efficacy and similar bleeding risk. And so we shifted to using low molecular weight heparin. And then more recently, after the pivotal trials with DOACs in non-cancer patients showed benefit, we started doing randomized controlled trials in specifically cancer patients, since the initial trials did not have a lot of cancer patients. And what the aggregate data, there have been several randomized trials now, the aggregate data shows that that DOACs do have a benefit in terms of recurrence risk compared to low molecular weight heparin, without at least an increase in major bleeding, but there is a risk increase in clinically relevant non-major bleeding. And so we do need to pay attention to that, especially upper GI bleeding in those patients with GI cancers. And so there are, advantages and disadvantages, and specific patients, I might choose low molecular weight heparin, and in others, I might choose a DOAC. It seems pretty clear that patients would rather take a pill than an injection, and that's very reasonable. So the way I think about choosing between the two is I look at tumor type. If someone has, for example, an unresected upper GI cancer, I might lean towards low molecular weight heparin. Some of the other things I think about are, can a patient swallow pills? Do they have severe mucositis? Are they having severe nausea and vomiting? Something that would preclude them from taking any sort of pill. I might lean towards low molecular weight heparin. I look at their organ function, hepatic and renal function. And so these are sort of, again, things that I look at when I'm trying to decide low molecular weight heparin versus a DOAC. And I go through all of these points with patients so they can be involved in that decision.
You mentioned the tumor type as being an important one, and that upper GI tumor, I'm thinking about the esophageal, the stomach, tumors, things like that. We know that there's that potential risk for bleeding. And so perhaps using an injectable kind of bypasses that. But the other question I get asked a lot is, what about patients who have metastatic cancer, and in particular, if they have metastases to the brain? Does that change your decision as to whether you're treating them or which agent you're using? How do you think through that situation?
Yeah, so it's an interesting question, metastatic versus primary brain cancer. It seems that metastatic cancer to the brain, that you could probably use either low molecular weight heparin or a DOAC. The risk of bleeding is similar. And in fact, the risk of bleeding is probably not any different than just their baseline risk. The primary brain cancers, interestingly, do have an increased risk of bleeding, and maybe slightly even increased risk with DOAC. So I tend to not use them. But I think this is very preliminary data. I think what we need are larger trials, and I know that's difficult in this population sometimes. So I think it's a hard question. Again, patient preferences really do make a difference here in those gray areas where we really don't know 100% what the right thing to do is.
So you mentioned the patient preference thing, and this is really important because there are lots of reasons patients may choose one therapy over another. One of them even is just the cost. And we know that both low molecular weight heparin and DOACs can have significant costs for many of our patients. Is there ever a role for warfarin in the treatment of a patient with cancer-associated VTE? Or in your mind, is that just absolutely never acceptable? How do you think through that question?
Well, I never say never. So I think, to have as many tools as possible or options as possible is great. And there's always going to be a patient population that is served better by warfarin. And you hit the nail on the head. In the United States, we have to deal with cost. That's a reality.
Yeah.
And some patients cannot afford low molecular weight heparin or DOACs. And so in those patients, it's not that warfarin doesn't work. We need to make sure that their INR is therapeutic, that they can handle all the logistic aspects of getting their INR monitored and the dietary restrictions. But if for whatever reason they cannot be on a DOAC or low molecular weight heparin, whether it's cost, some sort of side effect that they had, a fear of needles with low molecular heparin, these are real things that patients deal with. And so I do use warfarin in those circumstances. The other area where I'm not dogmatic about warfarin versus DOACs versus low molecular weight heparin is that time period after 6 months, or that after that initial period, right? We don't have a lot of studies that say what should we be using after that initial 3, 6, 12 months, however long you're going to treat that acute phase. And so, if a patient, for example, for cost needs to go back to warfarin, I don't say that that's not a possibility. I think that's a reasonable thing to do because we don't have data to suggest long-term that that's not the right thing.
Well, this is a really important area, and I was going to ask you about this. In the non-cancer patient, when they develop a DVT or a PE, we kind of think of that acute treatment period as being 3 to 6 months, and then we decide we're either done or they get extended, often indefinite anticoagulation. In the patient who has a cancer-associated VTE, do you have that same approach? It's 3 to 6 months versus indefinite, or do you have a different sort of mental model for how you think about the duration of treating patients?
Yeah, similar model. I would say it depends on the cancer. Is this a persistent risk factor? Is this a patient that has a metastatic cancer that we're using, palliative systemic therapies, but there is active disease? And we know that those patients have a high risk of recurrence if we stop anticoagulation. On the other end, they might also have a higher risk of bleeding. And that's the duality we have to deal with in cancer patients is they not only have a high risk of recurrence on anticoagulation, they also have a high risk of bleeding. And so what is that risk benefit ratio? But generally, if someone has active cancer undergoing active systemic therapy, I do continue anticoagulation long term. If, on the other hand, they are a patient with early stage cancer, resected, received their adjuvant chemotherapy, now in remission for all intents and purposes, no evidence of disease on surveillance scans, I do consider stopping anticoagulation. The other question is, do we drop down to low dose DOACs? If I'm going to keep them on long-term anticoagulation, since I consider my cancer patients the highest risk of recurrence, similar to my antiphospholipid syndrome patients or anyone else with a prothrombotic disease, I'm generally keeping them on full dose anticoagulation, barring any major bleeding kind of risks. But that's sort of how I think through whether to continue or stop anticoagulation.
Well, you mentioned one important piece there, which was the concern about bleeding. And we know that patients with cancer often are at increased risk of bleeding. And whenever I hear about bleeding and anticoagulation and VTE, the question that always comes up is, should we be putting in an inferior vena cava filter, an IVC filter? In your practice, when is it appropriate? And maybe more importantly, when is it not appropriate to put in an IVC filter for a patient who has cancer-associated VTE?
Yeah, so I know I just said I never say never, and I'm sort of close to that, but no, I think there's, again, always going to be a role for an IVC filter in a very small scenario of patients, and it's actually that group of patients that I think are suitable for a filter is getting smaller and smaller with the newer oral anticoagulants that have not only better efficacy but also lower bleeding profile. But what I would say is, I generally do not put IVC filters in prothrombotic patients. And to me, again, cancer patients, this is a systemic hypercoagulable state. So it doesn't make sense to me to put in a local mechanical device that, at least based on studies, show that it's only temporarily effective for preventing embolization from a lower extremity DVT to a pulmonary embolism. But long term, we know that they actually can increase the risk of lower extremity DVT and become more of a prothrombotic device. So I still consider IVC filters the one of the only indications for them are the patient that cannot get therapeutic anticoagulation for an acute VTE, because let's say they have active bleeding. And the classic example is someone who has intracranial hemorrhage and at the same time has a large proximal DVT. As far as patients who fail anticoagulation, or I should say anticoagulation has failed them, I think that there are so many other options now, and we have to really make sure it was a true failure. Was the patient on the right dose? Did they have some other drug that created a drug-drug interaction and lowered the concentration of the anticoagulant? Were they taking it at the right time with meals, for example, with rivaroxaban? So there are many other things that we need to think about before we truly label them as having failed the anticoagulant. And in most cases, you could switch to a different anticoagulant rather than putting in an IVC filter.
Well, one of the things you mentioned there, and I want to dig into a bit more, is that drug-drug interaction piece. And, I think for you and I, we often think about that. Did we get them on the right dose of their anticoagulant? We don't want to overdose or underdose. But I'm wondering, do patients often ask about this, particularly your patients who have cancer, and sort of how do they think about your recommendations for anticoagulation in light of the rest of their cancer treatment?
Yeah, and I think that's so important in our cancer patients because they are dealing with this major diagnosis of cancer. And when you tell them they have a blood clot, that's sort of a secondary priority for many patients. They've got so much else going on. They're getting chemotherapy or other systemic therapies. And so what's been shown is that in cancer patients with VTE, they have a few priorities that they want to make sure with their anticoagulant, that it doesn't interrupt their current therapies that they're getting for cancer, that the anticoagulant you're prescribing is safe and effective, and the route of administration does seem to make a difference for patients, with most preferring oral versus instead of an injectable. So I think those are the three things that come to the patient's mind the most. And as long as we're not interfering with their overall cancer therapy, most of the time they are very willing to start the medication for anticoagulation.
So as we think about the nuances of treating a patient who has a cancer-associated VTE, what guidelines do you tend to look towards to help you think through some of these decisions? Are there ones that are specific to cancer VTE, or are there just sort of the general VTE guidelines that we need to rely on?
Yeah, thankfully, there are several cancer-specific guidelines out there to assimilate the data in specifically cancer patients. And so my go-to guidelines include the ASH, the American Society of Hematology guidelines from 2021, which was specifically a chapter in cancer patients, and again, prioritized questions that are very relevant to our cancer population. The 2021 NCCN guidelines are also ones that I look at, and then the 2019 ASCO guidelines. So these are excellent guidelines. And then just recently, at 2021, there was the International Initiative on Thrombosis in Cancer. So those are kind of my guidelines I go to. They all prioritize some different questions. And so in aggregate, I feel like all of those guidelines give me all the information that I need.
Awesome. Well, we've certainly learned a lot in this discussion, and now we've got great resources to go to dig in a little bit further. Dr. Anita Rajasekhar, I want to thank you for joining us today, and I want to thank everyone who joined us on this podcast. Be sure to check out more at medthority.com. Go to the VTE Learning Zone to get more information about care of patients with venous thromboembolism.